This PowerPoint talk accompanies the chapter entitled Combining Radiation and Systemic Therapies for Treatment of Brain Metastases. In this short talk, we will cover 3 cases that highlight the efficacy of systemic therapy in the central nervous system and how this therapy may interact with radiation. Our first case is one of a 56-year-old female with a distant history of melanoma resected from her upper thigh 2 years previously. She now presents with symptoms of visual changes, headaches, confusion, and falls. MRI of the brain shows multiple small gadolinium-enhancing lesions on the T1 weighted scan, as seen in image B, associated with significant amounts of edema around all the lesions, as seen on the FLAIR scan, image A. CT of the chest, abdomen, and pelvis revealed multiple lung nodules, and biopsy of one of these nodules demonstrated metastatic BRAF mutant melanoma. Given the multiple small but symptomatic brain metastases, standard treatment would typically include steroids and whole brain radiation therapy. The success of whole brain radiation therapy, however, has previously been documented to be limited due to melanoma being a more radio-resistant pathology. For many centers, however, the more efficacious radiation option of radiosurgery is outside their capability given the significant number of lesions. In view of the above, this patient was started on combination targeted therapies, dabrafenib and trametinib, and at follow-up imaging at 6 weeks, it can be clearly seen that many of the previously documented lesions and the associated edema had resolved using drug alone, images C and D. Unfortunately, as is typically seen for these tumor types, resistance to BRAF therapy developed at 11 months, resulting in both brain and body progression, as seen in images E and F. It is important to note that many of the lesions that had been thought to have resolved have now recurred, and radiation therapy was administered at this time of progression. Given that resistance mutations are highly likely to develop in BRAF mutant melanoma, it is recommended that lesions are treated with radiation upfront, even though BRAF inhibitors alone are effective in the central nervous system. Our second case is a 90-year-old male who presented with pneumonia and was found on workup to have newly diagnosed KRAS mutant adenocarcinoma of the lung with a PD-L1 level of greater than 1%. CT of the chest, abdomen, and pelvis also showed adrenal and bony metastases. Staging MRI of the brain revealed a single asymptomatic right frontal lesion, as seen in image B, associated with significant perilesional edema, seen in image A. Given his older age, the patient refused standard chemotherapy and radiation, but agreed to start anti-PD-1 agent pembrolizumab, which he was able to do since he did not require steroids for management of his brain metastasis. Images C and D show his MRI scans after 3 months on drug alone. This favorable response mirrored a similarly robust response in the body. Images E and F show further improvement at 6 months, and his response in the brain was durable at last follow-up at 2 years. This case demonstrates that unlike targeted therapies, responses to immunotherapy tend to be durable and often do not require additional radiation therapy. In fact, if radiosurgery had been administered at initial presentation, some data suggests that this may put patients at a possible increased risk of the development of radiation necrosis. In addition, steroids should not be initiated unless patient is symptomatic at presentation to allow them to get best response to immunotherapy. Our last case is one of a 77-year-old female with a known history of EGFR mutant exon 19 deletion lung cancer, whose body disease had responded to first-line tyrosine kinase inhibitor erlotinib. She had been NED in the body for 2 years before she presented with progressively worsening headaches in the morning associated with gait imbalance and blurry vision. An MRI of the brain was performed, which showed a medial left temporal lesion but also evidence of enhancement of the folia of the superior cerebellum as seen in images A and B. Given the concern for leptomeningeal carcinomatosis, lumbar puncture was performed, which confirmed this diagnosis. Given that her disease was progressing on first-line TKI, and given there was still no evidence of disease recurrence in the body, her treatment options at this time included either whole brain radiation therapy, or a later generation TKI, or a combination of both treatments. For first generation TKIs, there is retrospective data suggesting that the combination of TKI agent with radiation results in increased overall survival and progression-free survival in patients with CNS disease. Given the patient's concern for potential neurocognitive injury and preclinical data showing a high degree of brain penetration of a later generation TKI called osimertinib, patient was started on drug alone. No data currently exists on overall survival and progression-free survival responses to osimertinib and radiation. Patient symptoms resolved within weeks of starting drug. Images C and D show response at 2 months to osimertinib alone, and images E and F show persistent response of both intraparenchymal and leptomeningeal changes at 6 months. While osimertinib can be effective for months to years, few salvage medical options are available at time of progression, and in this case, radiation therapy will likely be required at that time. Hopefully, these 3 cases have been able to highlight the benefits and challenges of the effect of systemic therapy on brain metastases for the reader. Thank you for your attention.